Broadcast is now starting. All attendees are in listen-only mode.
Welcome everyone, and thank you for joining us for today's webinar. My name is Madeline Enright and I'm a Project Officer at ACTA, the Australian Clinical Trials Alliance. The focus of today's presentation and discussion will be ethical considerations when using linked data for clinical trials, presented by Dr. Felicity Flack. And this is part 3 in a 4-part series on linked data for clinical trialists. Before we get to the main presentation today, I just have a couple of acknowledgements and housekeeping items. First and foremost, I'd like to acknowledge that this project has been a collaboration between ACTA, the Population Health Research Network, and the Australian Research Data Commons, who in turn receive support from the Australian Government through NCRIS. I'd also like to acknowledge the operational funding ACTA receives from the Australian Government's Medical Research Future Fund. Just a quick reminder that these webinars are being recorded and will be available on our website shortly. So if you've missed the first two or you want to review anything we cover today, please head over to clinicaltrialsalliance.org.au where you'll find the relevant links in our latest news section. If you have any questions during the presentation, please type them into the question box in your GoToWebinar control panel. We will have time for questions at the end and I'll try my best to read them all out to Felicity to address. Now, I'm pleased to introduce our presenter for today, Dr. Felicity Flack. Felicity is the Manager, Policy and Client Services for the PHRN, the NCRIS-funded National Data Linkage Infrastructure. In this role, she oversees the coordination of applications for cross-jurisdictional linked data projects, and she is also the chair of the Sir Charles Gairdner Hospital Human Research Ethics Committee and is writing a book on the ethics, law and policy of using linked data for research. Welcome, Felicity.
Thanks, Madeline. It's nice to be here in Melbourne with you today. We're usually only meeting via video. So thanks, it's good to be here. And welcome everybody else. Welcome to everybody who's been at the last 2 webinars and also to anybody who's new today. And I do encourage you to go back and look at the last 2 webinars to catch up and find out what else we've been talking about. But today we're going to talk about ethics and linked administrative data. But just to remind you what the overall objectives of the 4 webinar series that we're running are. Firstly, we want to be able to demonstrate the benefits of using linked data in clinical trials research, to assist clinical trials researchers to design clinical trials using linked data and apply for access to linked data, and to introduce clinical trials researchers to the PHRN facilities and services available. Okay, things are not moving. That's better. Okay. But the objectives for today's webinar are firstly to explain the key ethical issues related to accessing linked administrative data, then to describe the legal framework applicable to accessing linked administrative data without consent, and to help you understand some of the strategies to demonstrate respect in the absence of consent. So I'm just going to start off by a quick refresher because I'm sure you're all very familiar with the core values that the national statement are built around. And the conversation today is going to focus around these 4 core values. Firstly, research merit and integrity, justice, beneficence and respect. And these are the core values which you should be designing and conducting your clinical trials with, but also are the basis on which ethics committees will review your applications. Because this is quite a text-heavy talk, I've interspersed it with a few photographs just to give you your eyes a bit of a rest. So enjoy the autumn leaves for a moment. Right. The first section of today's talk, I'm going to focus on ethical considerations for all studies involving linked data. And then I'll move on to some of the specifics around when you're using linked data with consent and then when you're using data without consent. But first of all, what are the things that you should be taking into consideration in all of your clinical trials using linked data? And the first value is research merit and integrity. And this is the concept that research is only ethical if it's well designed and able to result in a valid or significant results at the end. It's not okay to ask people to participate in research if the research has no hope of reaching any valid results. It's also important that the researchers who conduct research have integrity, and that means that they behave with integrity and they also have the skills and experience to conduct the research that they've proposed. So how does this be taken into consideration, particularly with regard to using linked data? Well, I'd really refer you back to our first webinar, and it's about how well is the project designed, and is the data that you want to use actually available? Is it feasible? Are the variables that you need available and able to answer the questions that you want to answer? And have you chosen appropriate methodology to answer the question? And then as far as the researcher's integrity, you need to ensure that your research team have the necessary training and experience to conduct the analysis and manage the data. And this means that you either need to ensure that your research team includes appropriately trained researchers, or you need to go out and get some training yourselves. The next core value, which is beneficence, and is the core value that most people think about when they think about what an ethics committee does. They think ethics committees balance the risks and benefits, and that's essentially what beneficence is. So it's that the likely benefit of the research must justify the risks of harm or discomfort to the participants. But it also extends a little further than that, and the national statement is very clear that researchers need to be sensitive to the welfare and interests of people involved in their research and reflect on the social and cultural implications of their work. So this is the thought that the risks and benefits balancing act needs to go beyond just will there be physical harm to the individual participants. It extends to both the benefits and risks to the individual participants, but also to the community as a whole and subgroups of the community who may be affected by the research. When you're thinking about whether the core value of beneficence has been met, this is essentially the steps that you'll need to take. Firstly, to identify the risks and benefits, to work out to whom the risks and benefits apply, what the likelihood and impact of the benefits and risks are, and then to work out how you're going to minimise and manage the risks and maximise the benefits. So let's talk about that a little bit more. What are the sorts of benefits that might arise from using linked data in your trial? Well, things like being able to do long-term follow-up over many years of your clinical trial cohort, for example. Also the possibility that you could know and understand more about your cohort prior to them enrolling in your clinical trial, so the inclusion of pre-recruitment measures. The possibility that you might be able to include a broad range of measures and outcomes that beyond the specific clinical outcomes that you might usually measure, including things like social and other non-health outcomes. Some of the benefits might be being able to continue to follow people who've been lost to follow-up, dealing with reporting and recall bias, and it also can be cost-effective and less expensive to use linked administrative data than to prospectively collect your data. We think about risks. It's not just about identifying what the risk or harm is. Sorry, people can't see me.
That's all right. We've just turned it off.
We've just turned it off, okay. Then national statement says that you have to also work out what the likelihood of that harm occurring is and what that severity of that harm is. So that helps you with this balancing against the benefits that you've identified. So it's really important to think quite particularly about what the harms and discomforts really are and how bad they are. And risks fall into a range of different categories, including physical harms, psychological harms, social harms, economic harms. And as clinical trialists, you'll be very familiar with trying to assess possibilities of physical harms to people. But the harms associated with using linked data are less likely to be physical and more likely to be psychological, social, things like stigmatisation, discrimination, potentially economic harms, things like people's insurance being affected because of knowledge that comes out about them, those sorts of things. So you have to think well beyond the physical harms when you're thinking about what kinds of harms could come from using people's data. So once you've identified what the harms might be, to help you identify them, you should firstly identify all the data sources that you're going to use in your trial. And this will be the data that you're collecting directly from the participants, data that you're collecting from medical records, and data that you'll be linking to administrative records. And draw yourself a flow diagram of all those data sources and how that data is going to be moved and changed throughout your research project. And once you've drawn that flow diagram, so you might collect data from the patient, it then will get stored at the clinical trial site. It might then have the names and addresses removed from it and stored separately. Then there might be content data sent to a central coordinating site. That flow of data throughout your project needs to be carefully understood. And then you'll need to work out who's going to have access to the data at the different points throughout your trial. And once you've got this information, it will then be easier for you to actually identify what the risks or potential harms are at the various stages of your project. So that takes us to evaluating the risks. And identifiability is often described as a harm or a risk. And the fact that data is identifiable is not necessarily a harm, but it increases the risks that harms may result. So it is a very important thing to understand about your data. The other common misconception is that identifiability is an intrinsic value of data, and it's not. How identifiable a data is depends on a range of things, such as the type of information. So, for example, a full date of birth is much more identifying than a year of birth. Also, the quantity of information. So the more information you have about an individual, the easier they will be to identify, even if you don't have their name and address. The next thing that affects the level of identifiability is the other information that's available to a person who has access to the data. So, for example, clinical trial staff at a particular site who are also involved in clinical practice may well know the patients that come into their unit very, very well. And it's much easier for them to identify people from the clinical trials data from their site than it would be for people from another site who are unfamiliar with that patient population. So the information that they have access to and just know in their heads makes that data more identifiable to them than to others. And the final thing that does affect the identifiability of data are the skills and technology available to the person who has access to the data. So, for example, my mother has very few computer skills, and her ability to re-identify someone from doing a Google search is very, very limited. But in contrast to people who have highly developed skills in encryption techniques, for example, they have lots of skills, technology and software available to them that make it much easier for them to identify people in the same set of data that my mother wouldn't be able to do. So the really important thing to keep in mind is there's no such thing as just, oh, I took the names and addresses off and the data was de-identified. You have to think more deeply at every point in your trial about what the actual risk is, and it depends on what the data is, how much data, and who's going to have access to it, the level of identifiability. Now, the new release of the National Statement in Element 4 has a lot of really helpful information about evaluating the risks of identifiability, and I really encourage you to read that. So once you've evaluated and identified the risks, your next task is to minimise risks. And there are sort of three main things to think about when you're minimising risks. The first is only collect the data that you need for the trial. Don't collect data for a rainy day that you don't know what you're going to do with and you don't have any purpose for at the moment. Second thing is to separate data. So we talked about last week how data linkage units and data custodians separate data in order to minimise risks, but you should also be thinking about doing that within your research group. That is separating names and addresses, those sort of overt identifiers, from the content data, the rest of the record, the diagnosis, the clinical details, those sorts of things. They should be separated as soon as possible and stored and managed separately. And then the third thing that many people don't think about is role separation. Within your research team, there should be very clear descriptions of roles and who has access to what data and for what purpose at what time. And ideally, people who have access to fully identified data should be separate from people who are just analysing the content data. Example. Once you've minimised the risks as much as you can, then you need to manage the remaining risks. And this is really your data management plan. And the national statement and every ethics application you fill out is going to ask you for a data management plan. And the things that need to be included in your data management plan are the physical security, so actually where is the data going to be held, stored, analysed. And this includes, it might be on site at your university or your hospital, or it might be stored in a data centre, for example. You need to know and have chosen that physical location to be appropriate for your particular case. You also should have all the appropriate policies and procedures around how you handle and manage data. These may come directly from your institution, who may already have data management policies and procedures, but you might also need to develop specific ones for your particular research project. There will also be contractual and licensing arrangements, particularly when you're linking administrative data. You will always have confidentiality or data sharing agreements with government data providers, and you'll need to make sure that you're adhering to those contracts. You need to think about what training in data management, privacy and security is going to be required for your research team, and the form in which data is going to be stored. So will it be encrypted, not encrypted? Will it be separated, not separated? These sorts of things are really important for you to think through and make appropriate choices for the level of risk of the data that you're handling. You also need to be clear about what purposes the data that you're holding and analysing is able to be used and or disclosed. And this means having a knowledge of what data agreements you've signed, which will probably specify the purposes to which you're allowed to use data or not. And then in this day and age of more open data and journals being very keen for data to be made available to other researchers for further analysis, you need to be sure about the conditions that you're allowed to share or disclose the data that you have, and how you're going to make decisions about who gets to see that data and use it or not. And finally, you need to include in your information sheets for your participants sufficient information about the data management plan for them to know exactly how you're going to handle the data. So there's quite a lot of information there about data management. The ARDC also has some helpful information about writing data management plans, and many universities also have templates and ideas for how they like data to be managed, which are worth looking up. There we go. So we finished that section on ethical values that are appropriate that we need to think about for all clinical trials research. But let's move on to thinking about access to linked data with consent. And I'm assuming that for most clinical trials, the default will be using linked data with consent. So the most important core value that we need to take into account when using data with consent is respect. And this is what the national statement says about respect. Respect for human beings is a recognition of their intrinsic value. In human research, this recognition includes abiding by the values of research merit and integrity, justice and beneficence. Respect also requires having due regard for the welfare, beliefs, perceptions, customs and cultural heritage, both individual and collective, of those involved in research. And that's quite a broad and encompassing definition of respect. However, when we're thinking about clinical trials, mostly, and really the Declaration of Helsinki and similar international ethics guidelines have a significant focus on equating respect with the autonomy of individuals and allowing individuals to make decisions for themselves, which is informed consent. So that's mostly what we're thinking about when we're thinking about using consent. Of course, there are other ways to demonstrate respect, which we'll talk about a bit later. So it's really about providing participants with sufficient information so that they can really understand what you're proposing to do with their data, what you're proposing to link it to, and why you're proposing to do that. So I suggest in your information sheets, this is the kind of information that you need to include. Firstly, the fact that you are planning to link participants' data with data from other sources, and being quite open about the fact that this may be able to identify them, because you will need to use identifiers to ensure accurate linkage. The more specific you can be about what data is going to be linked, I think the easier your path through the ethics committee will be. So if you're quite specific that I want to link my clinical trials cohort to admitted patients' data and death data, that's clearer and more specific. Of course, there are circumstances where you might want to be asking for a broad consent. For example, you might be wanting to set up some kind of biobank in which you don't know exactly what research is going to be used, and maybe not even what data you want to link to in the future down the track sometime. In that case, a more broad consent might be appropriate. You also should let the participants know who's going to conduct the linkage. So it's going to be conducted by the New South Wales Linkage Unit or the West Australian Data Linkage Branch, and some indication of how linkage happens, that you'll send their names and addresses to the linkage unit who'll link it to the other data collections you're interested in. It's also important to let them know why you want to do this and what will be the benefits from linking their data and what are the risks, and be very clear about how you're going to manage the risks. That brings you back to their data management plan. The other thing you should consider is this data linkage optional or mandatory? Is this just a nice to have, and that if people are happy to let you link their data, then that would be great? Or could the trial not go ahead if you don't have access to linked data? And you should be quite clear about that. You also should include some wording in the actual consent form to be specific that you are asking for consent to link data. And there's just some example wording there that you might like to consider, but not set in stone. You should think about what's best for your particular case. And finally, just a comment about MBS and PBS data. If you want to link to MBS and PBS data, you absolutely can do this. And with consent, you'll do this via the Department of Human Services. They have a specific information and consent form that must be completed before they will release data. That changes from time to time, so the best thing to do is to contact them as soon as you know that you want to access PBS and MBS data and get a copy of the latest version. I did ask them recently if you could use e-consent forms, and the answer was yes, as long as you include the exact wording in your e-consent form. So that's useful to know for those of you who are moving to e-consent forms. So that's the end of my section on using consent. And the last section of the presentation, I'm going to focus on access to linked data without consent. Now, as I said, I think we really should assume that if at all possible, you get consent from people to access their linked data. But there are circumstances where that may not be feasible and it would be more appropriate to do it without consent. It may be more likely to occur if you need to do some kind of epidemiological study in association with a clinical trial, perhaps, which would be more likely to be done without consent because you would need data from the whole population. You might be doing some kind of health economic analysis, or you might want to do a long-term follow-up many years after a clinical trial was conducted and linked data wasn't thought of at the time when the trial was conducted. There's no guarantee in that last scenario that you would be able to be granted a waiver, because some ethics committees may still take the stance that you had the opportunity to ask when you got consent for the trial and you should have done it then. But that you may be able to put a case for a waiver. So let's think about waivers. There are two aspects to getting approvals for a waiver of consent. There are many legal requirements that have to be met, and there are also ethics requirements. So I'm going to talk you through both of those, and we're going to start with the legal requirements. So access to linked data with consent brings into play at least three different areas of law: empowering legislation, the duty of confidentiality, privacy legislation, as well as any contractual obligations that you might have in signing data confidentiality or transfer agreements. So this is very complicated and overlapping and complex area of law. So what I mean by empowering legislation, and here is an example of the WA Cancer Registry. Empowering legislation is legislation that allows and states that the government can collect data and the purpose for which they can use this data that they collect, and in what circumstances they're authorised to disclose the information. So in this case, it's quite a nice example because it's quite clear that the government is allowed to collect the information. In fact, it's mandatory to collect information about cancer diagnosis, and the reason that it's collected is to carry out research into the causes, prevention, screening and treatment of cancer, and that the Chief Health Officer may authorise to disclose this information for the purpose of the research, as long as it's approved in accordance with the national statement. So that's empowering legislation. And for most big government administrative data sets, there is some form of empowering legislation. It may not be so clearly written as this as to what you're allowed to use the data for and who you can disclose it to, which can lead to some complications. The second area of law is the duty of confidentiality. And those of you who are healthcare providers should be very familiar with the duty of confidentiality. This is the relationship that you have with a patient when they provide information to you when they're seeking treatment. And this duty extends to anyone who later receives that information. And it says that the information can't be used for any purpose other than the purpose for which it was given. But of course, there are exceptions to this. So if a person gives consent for you to use their data for another purpose, for example, research, or there's a public interest that outweighs their confidentiality, or there's statutory authority, i.e. there's empowering legislation that says it can be used. Then the third body of law is privacy legislation, and this is what people mostly think about when they think about using data without consent. It's strangely sometimes more enabling than the other areas of law. And the things to note are state and territory governments have different privacy legislation. The Commonwealth Government has privacy legislation, and some jurisdictions, South Australia and Western Australia, don't have any privacy legislation. But all privacy legislation in Australia does have a research exception and usually requires an ethics committee to review an application in order to make the use of that data lawful. So to summarise, the most important body of law is actually the statutes authorising collection of use and disclosure. And you're not breaching those statutes when you comply with the statute. You do what the statute says. The second is the duty of confidentiality. And you're not breaching that if you get consent or if there's statutory authority. And then the third area of law is privacy legislation. And you're not breaching that if you get consent, there's statutory authority, or you fall under the research exception and you get HREC approval. So as I said, it's a bit complicated, and it's no wonder that people get in a bit of a mess when they're thinking about how to get approvals for waivers of consent. So one helpful thing to think about is how to map information flow in your project. So I mentioned earlier, when you're doing your data management plan, you should draw up a data flow diagram, which should have different steps of what happens to the data as it moves through your project. If you map these steps against what kind of organisation's involved, whether it's collection, use or disclosure, is it personal information or not personal information, is it health information, you can start to draw a picture of what legislation applies to your particular project. And it might give you a better feeling for what sort of things you need to comply with in order to be acting within the law. Now let's think about the ethics requirements for waivers of consent. So there's sort of three main areas that ethics committees are considering when they're reviewing an application for a waiver of consent. Firstly, that it's necessary to use identified or potentially identifiable information. Second, you have to prove that it's impractical for you to gain consent, and also that it's in the public interest for you to do this. The waiver of consent actually has 9 separate criteria, and you have to address each of these criteria separately and explicitly. If you don't do that, it becomes quite difficult for ethics committees to review your application. And some of the criteria are quite straightforward and relatively easy to answer. But in my experience of reviewing these applications, there's 2 of the criteria that are particularly tricky. And the first is that the benefits from research justify any risks of harm associated with not seeking consent. It seems to me that mostly researchers misunderstand this criteria, and generally the answers we get are just a list of benefits and risks and a statement that the benefits outweigh the risks. But the question's actually more specific than that. It's asking about risks of harm associated with not seeking consent. And the main harm associated with not seeking consent is the possibility that the community may lose trust in the health system or their health practitioners. That is, at the moment, patients share confidently with their health professionals intimate and sensitive details about themselves because it's on the understanding that that data will only be used by those health professionals for the care of the patient. But if patients start to feel that their data is being shared and distributed for purposes that they are not supportive of, then they may start to not fully disclose information to health professionals, and that's a big problem for the health system. So that's what this criteria is asking. Are the benefits of this trial worth taking the risk that people might lose trust in the health system? And if you think about that in your response, that will be really helpful for the ethics committee in their consideration. The second criteria that's really tricky for everybody is there's no known or likely reason for thinking that participants would not have consented if they had been asked. And there's no way that anybody can know what's in the minds of every single participant, particularly if there's a million of them. But the criteria still has to be met, and the ethics committee have to have some reason, some evidence to make them decide that that criteria has been met. So the things that you can provide to an ethics committee that will help them are, firstly, perhaps you've done some research in the same or a similar research group before with consent, and you had really high response rates. So you've got some evidence that that group of people are keen and happy to participate in this kind of research. The other thing you can do is have some community involvement in your trial. So you might have a community advisory group, or you might have done some work before you started the trial about understanding communities' needs that would suggest that there was strong community support for this trial. So that's the sort of thing that would really help an ethics committee. And then the final thing you need to think about is, how are you going to demonstrate respect in the absence of consent? So we talked about earlier the fact that getting consent is a really important way of demonstrating respect to participants, but when you're not asking for their consent, you need to think really carefully about how you're going to demonstrate that. And the first important thing to do in demonstrating respect is, when you get the results of your study, you need to make them available to both the participants and the general community in a format and in a media in a way that is accessible to them. So just saying it will be published in a peer-reviewed journal is not sufficient. That information is really not available or easily understood by the general population. So you need to think about, is there a website? Is there a community group you're going to distribute the information through? Those sorts of things. The next thing is to think about, well, community involvement in the project from the start through to the finish in various ways is also a way of demonstrating respect to people. And that may be assistance with study design or ideas for what's important to be looking at in the clinical trial in the first place, through to community advisory groups, those sorts of things. And then another way of thinking about demonstrating respect is about translation, and thinking about how can the results of this study be best translated into action, whether that be change in service, change in practice, or even informing what the next research is, thinking how best that information that you have collected and that knowledge that you've gained can be put to demonstrate the benefits that you claimed at the start were possible. Right. Now, just to finish off with one final note, and it's about specialist ethics committees. For access to administrative data in many jurisdictions, it's mandatory to go to one of the, usually sit in the health department ethics committees. And this is just a list here of those specialist data or population health ethics committees that you will be required to go to. Just thought that would be helpful for you to note. So even if you have got an ethics approval for your trial, for example, from a hospital committee, you still will need to go to one of these specialist data committees. And that is the end from me today. Thank you again to the ACTA Reference Group 8, the other researchers who've provided feedback on the webinar materials, the ARDC support for the webinar platform, for the PHRN and NCRIS, and also for this particular webinar, a special thanks to Judy Allen and Kate Tan, who I worked with years ago on developing some HREC training for HRECs around the country. Now.
Great. Well, thank you so much, Felicity. So we'll go ahead and take some questions now. So just a reminder, please make sure you type your questions into the control panel. You should be able to see a questions box there. So we'll just give people a few minutes to come up with their questions.
Stunned silence.
Apparently so. Okay, so we've got a few coming in now. One question relating to biobanks.
So the question is, you mentioned biobanks during the first half of the talk. With several policies around biobanks and your institutional policy, how do you ensure you abide by all when you link data sets and draft your data management plan? It can be quite complicated. Unfortunately, I think you actually have to understand all of the policies that are relevant to all of the data that you're collecting. And most things will actually have significant overlaps. They might be written in slightly different wording, but the overall principles will remain the same, I think so.
Okay, great. Now we've got another question here about an example for a waiver of consent. So are there any that immediately spring to mind? Any projects that you've approved or worked on?
Well, we do all the time, sort of on a daily basis, waivers of consent for linked administrative data. So linking hospital, death, emergency, PBS, MBS, all sorts of projects involving linked administrative data happen all the time. I think there are less examples of where waivers might have been used specifically in clinical trials, and I'm struggling to think of one off the top of my head.
Okay, perhaps that's a question that we can address after the webinar, and we can find some examples and send them through. We've had another question here come in from Catherine. Can you give an example of a data linkage application that was not approved, and what were the issues with it?
Projects not getting approval are actually surprisingly rare. What usually happens is that both the data linkage unit and also the ethics committee will work backwards and forwards with the researchers until there's a design that everybody thinks they can go forward with. So that's the most likely scenario. It's an iterative process and you'll go backwards and forwards. To actually not get approval outright would be relatively unusual.
Okay, great. We've had another question come in about low risk. So is linked data ever considered to be low risk?
Now this is a tricky one with the national statement. So yes, it is low risk, but it is not eligible for a low risk review pathway. All projects involving waivers of consent must go to a full HREC, and that's what the national statement says. But that's not to say that they're high-risk projects. By the definition in the national statement is that they mostly don't cause more than discomfort. So.
Okay, so if anybody has any last-minute questions, we might just have a couple more minutes of those. So Mamta has just asked if we have any further resources that they could refer to on data storage and data linkage and sharing with researchers. Okay. So I think we do have some good news in that regard.
We do. So we're putting together a guidebook based on the content that's in this webinar series together with ACTA, and I'm not sure when that will be published, but hopefully before the end of the financial year. So that'll come out. In the meantime, please go and have a look at the PHRN website. There is some more information there. Contact us if you have any specific questions. And if you want to know more about data management, the ARDC website also has some good resources on data management.
Okay, well, thank you so much, Felicity. It looks like we've covered all the questions there. So thank you so much, and thank you everybody for your contributions today. So remember to head to our website for recordings of these webinars, as well as news about other upcoming events. Thanks again for joining us today, and we'll hopefully see you next week for part 4, the final part in this series, where we'll examine utilising MBS and PBS datasets with Dr. Anna Kemp-Casey. Thank you so much, and bye for now.